everyone to today's program. It's my pleasure to welcome everyone to today's program. This is just one of our series of programs that we run in Salam Sisters. Before I introduce the guest speaker, I would like to just introduce myself as Amina Suleiman. I should really be joining from Liverpool, but as Allah will have it, I'm joining from Manchester. Co-host this program with me today is my lovely sister. Sister Yetunde, could you introduce yourself, please?
Assalamu alaikum. Thank you very much, Haji Sulaiman. Because I'm here today at Evangelio, and I'm speaking to you from Accra in Ghana. Thank you very much for joining us. Assalamu alaikum.
Thank you very much. So Sister Yetunde is joining us all the way from Ghana, Accra. I'm just going to give opportunities for 2-3 people. If you would like to just introduce yourself, you can raise your hand, we could call you, or you could just type on the chat box your name and where you're joining from. Bismillah. Yes, Sister Adeniji Mariam, yeah, you have the floor. You need to unmute yourself. Okay, Rahma is also co-hosting this with us, all the way from Liverpool. Yes, Sister Mariam.
Assalamu alaikum. My name is Aden Jimari. I'm calling from Lagos, Nigeria.
Thank you for joining us, Sister Mariam.
Yes, ma'am.
And I would like to acknowledge everyone who has been here. Elijah Aure, you have the floor. Unmute yourself, please. Bismillah, Elijah Aure. Or is the problem with the audio? Well, there will be opportunity. Yes, Sister Fatima, Bismillah.
Assalamu alaikum warahmatullahi wabarakatuh. My name is Fatima Mouili, calling from Houston, Texas, United States of America.
Jazakallah khair for joining us. What is the time there now, Sister Fatima?
It's 8:04 a.m.
Oh, bless you for waking up early to join us. We pray it benefits all of us. You're welcome to the program.
I mean, thank you.
Right, that is how we'll have the time to take. That much to do, we're gonna start the program. Just a few housekeeping. Just as we are, nicely everybody joining in, muted. The only time you should unmute, please, is when you've raised your hand and you've been acknowledged to either contribute or to ask questions. We also would like that your video is also turned off. When it gets to the question and answer session, you will be able to ask your questions, to make your comments. But in the meantime, as the lecture is going on, you can type your comments or questions in the chat box. We have sisters monitoring the chat box and they will be collating the questions. But equally, you will have the opportunity to speak, to ask your questions. Right, Sister Yates, are we ready to roll?
Bismillah, sis.
Okay, thank you. Right, now I've got a confirmation from my co-host. I would then like to introduce the topic for today. It is something very, very important. We all know the importance of sight. It is one of the blessings of Allah. And it's also so important. There is actually a supplication recommended in authentic hadith that we usually pray, oh Allah, grant my sight good, my hearing good. That shows us one of the importance of sight. So to discuss a peculiar problems with the eyesight, which is glaucoma. Well, depending on which part of the world you are, you can say glaucoma. I'm saying glaucoma. The silent visual extinguisher. And we'll be looking at today's topic, inshallah. What is this glaucoma? What causes it? How to identify it, and possible treatments, and all other topics related to it. And to really dissect this topic for us today, we have a specialist in this field, mashallah, by the name of Dr. Halima Alimi. She is our guest speaker for today. Dr. Halima is the medical director of An-Noor Eye Center, and she's also the executive director for one of these children charity organizations that looks into eye problems, especially in children. Towards the end of the program, she'll be telling us more about that organization and what they do, inshallah. So can I just welcome Dr. Halima Alimi. Bismillah.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi wa barakatuh.
So thank you for having me. My name is Halima Alimi, and today I'll be talking about glaucoma. I'll start by sharing my screen so that we can all okay, can you see this? Can everyone see my screen?
Yes, we can.
Yeah. Okay, right. So, okay, so I'll start. Just a moment. Right. So the topic for today is glaucoma, which we've tagged the silent vision extinguisher. And so I thank Salam sisters for giving me the opportunity to jump up and talk about one of my favorite topics, for the reason that even though glaucoma is a disease that has wreaked such horrible havoc on people's lives, it seems a lot of people still don't know about this disease called glaucoma. And even those who do are sort of nonchalant about it. And so every opportunity I get, I jump up to talk about glaucoma. It's called the silent vision extinguisher because of the name, the nature of the disease. It's silent, and then yet it can cause blindness. Other people call it the sneak thief of sight. So I'm sure these phrases give you the idea about what sort of disease we're talking about. So we should start by, sorry, just a moment, yeah. So we should ask ourselves, so what's glaucoma? So as a background, I'll tell you that glaucoma is a condition in which the nerve of the eye is gradually being destroyed as a result of high pressure in the eye. And so we all have the nerve that transmits images from our eyes to our brain back and forth, attached at the back of the eye. And it needs to be in good condition and depends upon good blood supply for its nutrition. And so once there's a problem with high pressure in our eyes, it doesn't allow the nerve to get good blood supply. And in so doing, it starts to decrease in function. This is glaucoma, and it can happen at any age whatsoever. There's no one can escape. A newborn baby can be born with glaucoma, and that's called congenital. It can happen in early childhood, early adulthood, called juvenile, and it can also start as an adult. You can also characterize glaucoma in several ways. You can call it primary or secondary. Secondary when there's a cause, a known cause, and we'll talk about the causes later. Primary when there's apparently no cause, just the disease starting up at some point in a person's life on its own. Now, this is my illustration of a congenital glaucoma. So the baby on the right side of your screen, nice, beautiful, normal eyes, you get a sense of what proportion there should be distributed between the white part of the eye and the black part of the eye, well, at least what we perceive as the black part of the eye. Now, if you look at the baby on your left, you get a sense that that round black part of the eye has taken up too much space, and the eye looks disproportionately large generally. So this is a child that's born with glaucoma. And so it's good to understand, for all of us to understand, that Brand newborn babies can have glaucoma, and the eyes look large. We call it ophthalmos, which means bullseye, because of the pressure expanding the eye like a balloon. This doesn't happen in adults. When you have glaucoma starting up in adults, the eyes are not expanded like this. That's because the eyes are already mature and the tissues are already set, and so they don't balloon in the same way a baby's eyes would. Now, the glaucoma is the king. It's the leading cause of irreversible blindness worldwide. Anywhere in the world, if you take any region and worldwide statistics, when you characterize blindness as reversible or irreversible, if you have reversible blindness, what that means is that with the surgical procedure, you can regain your vision. And that's what happens with cataracts, which is what people know popularly. However, glaucoma, which is less well known, is actually the leading cause of irreversible blindness. So once a person goes blind from glaucoma, unlike with cataracts, with glaucoma, that's it. It's gone, irreversible. And so glaucoma is actually the commonest cause. Let's look at some worldwide statistics about glaucoma. About 11 years ago, the World Health Organization estimated that there were, at that time, all over the world, 60 million people with glaucoma. And as if that wasn't bad enough, they had a projection that in 10 years from that point, there'll be 80 million. That was 2 years ago. This is the year 2022. And so it's easy to imagine that we probably have a little more than the 80 million, which was projected then. And if you talk about blindness, those who are actually blind from the disease, it's gone up from 8.4 million worldwide about 11 years ago or 12 years ago to slightly over 11.2 million now. And so these are really grim statistics. And so we need to be taking this disease serious and really look at it and look at what we can do for ourselves. Now, in Nigeria, for instance, in a survey, nationwide blindness and visual impairment survey done about 7 years ago, it was estimated that between 1.1 and 1.4 million people have glaucoma, and most of them are unaware, usually just incidental findings. And that's because of the nature of the disease. It's silent, and so it can fester without a person even knowing that it's there. Now, 1 in 20 people over the age of 40 have glaucoma in Nigeria, and 1 in 5 of such people are blind from the disease. In the US, it's estimated that about 3 million people at this point and over 120,000 blind. Let's make an attempt to make you understand the mechanism, how the nerve gets damaged. Now, this is a picture on the left side of the screen that shows an eye. And so this is a section in which the left part of the picture is the front part of the eye, and the back part that looks like a stalk is the nerve where it attaches. You can see those blood vessels. Now, those are the blood vessels that supply the nerve. And so if you look at the picture on your right, you see how pressure puts, pressure in the eye presses against that nerve. And so when there's high pressure in an eye, it pushes backwards. And that pressure is directly on the nerve, causing damage to that nerve because it's starving it of its blood supply. When we look in the eye as practitioners, this is what we see. The picture on the left is a normal nerve, nice and round, pink, evenly pink, and you see the vessels coming out from the center and fanning outwards. However, when a person has glaucoma, what we see when we look in the eye is a picture you can see on the right side in which the nerve is eating into. So that pressure acting backwards has eaten into that nerve. We call it cupping. And you can see how it's pushing the vessel to one side. And so that pale area represents an area that has been destroyed of the nerve. And so you can see that this person has approximately 60 to 70% of the nerve already destroyed from glaucoma. Let's talk about the causes. I get asked very often, what are the causes of glaucoma? The vast majority of glaucomas are hereditary. There's no real reason why it happens. It's a tendency that a person has inherited. And so when you see a person with glaucoma, most of the time, there's a glaucoma gene, G-E-N-E. There's a glaucoma gene in the family. And so it might not necessarily be your parents. The reason, a lot of the time I tell patients, when I get asked, what has caused this? And I say, well, it's genetic. And people say, but none of my parents have it. And I tell them genetic characteristics doesn't necessarily have to be your parent. Now, it could be your parent and you don't know at that point, but it doesn't have to be your parents. Just like with looks or any features or character, inheritance, it's a huge gene pool that you pick from your mother's side, your father's side, all other interconnected relatives. And so you might have a child that doesn't exactly look like mommy or daddy, looks like some grandparents or some distant cousin. So the tendency is the same. So a person might inherit a tendency from parents, or it might be from some distant relative you never met. And so we don't know our extended family trees that well. And even when we do, a lot of people in Africa, we take our medical history to be personal to us. We don't declare, we keep it secret, sacred to us. So we find that a lot of the time, a person might have a disease and never declare, especially if he doesn't have the information that is genetic, and therefore he should tell his family members to check. And so these are the various reasons why it may not be obvious that it's hereditary. The other peculiar thing about glaucoma is we don't know why it starts earlier in some people than others. And so I have diagnosed children before parents, a child with glaucoma, and then parents don't have anything at that stage. And sometime later in life, one of the parents, the person from whom this person got the tendency, develops it later in life. So we don't yet understand what the trigger factor is. Now, I mean, as in what triggers it to start at a certain age. Now, injury to the eye can also cause glaucoma. That's a secondary glaucoma now because there's a cause that is known. So some injuries can lead to high eye pressure, inflammation in an eye. So an eye, when it's inflamed, it's red. And there are various things that can cause redness. If it's an inflammation from within the eye, then if it's not properly treated, this can lead to glaucoma. And this is the reason why we tell people not to use home remedies or take it for granted that they can just treat with anything they find from a pharmacy when they have a red eye. You must go and have it checked out to be sure that it's not a cause that needs to be properly taken care of for it not to lead to an inflammation and subsequently glaucoma. Drugs can also cause glaucoma because some people abuse steroids, especially young men, undergraduates, they're building muscles, and then they take prednisolone. Also, you have people who naturally are on steroids to treat a disease. When they're overused, it can cause high eye pressure. And then you can have developmental abnormalities. I showed you a baby earlier on with, really large eyes. So the drainage mechanism in the eye didn't develop properly. And so that's why the child ends up with excess fluid and excess pressure in the eye. Abnormal blood vessels, especially in diabetics, when it forms, can cause glaucoma. Now, there are certain factors that are recognized to be highly associated with glaucoma. If you belong to these factors, if you have these factors, the tendency to have glaucoma is higher, at least this sort of glaucoma, the primary glaucoma. So we say age. Age is an important risk factor because if you study population groups, you will find out that the older groups, if you take people in decades, you'll find out that the prevalence, the number of people with the disease increases as you increase in age. And so if you take people in the 5th decade, you'll have more glaucoma cases than if you take people in the 2nd decade. And so all of us have a basic risk as we get older, so we need to be checking. Family history is a very strong risk factor. If you have a family member who has glaucoma, you should be checking your eyes. You have a risk factor. Short-sightedness, if you're myopic, this is also recognized to be a risk factor for a type of glaucoma. Race. So those of Afro-Caribbean race have a greater tendency to develop glaucoma. It's commoner in us. It comes earlier, it's more aggressive, it's more blinding, and compared to, say, for instance, Caucasian populations. And then if you have a systemic disease that coexists, with, that you have it, diabetes, hypertension, other vascular problems, your tendency to have glaucoma is already higher. So these are recognized risk factors. Now let's look at the symptoms of glaucoma, and I need us to pay absolute attention to this. In the early stage, no, nothing, absolutely nothing. It's very important that we recognize this because this is where it's really important, whether you take the eye health seriously at the point when you have glaucoma, but you have no symptoms. And so oftentimes people find it difficult to believe when we look in an eye and we say to them, you've got glaucoma, because at that point they can still see very clearly. And so they doubt the diagnosis. And this is the point at which treatment makes a difference. Because like I've said before, any damage done by glaucoma is not reversible. And so you want to act at a time when there's little or no damage, when it's obvious that the person has developed this disease. Later on, with significant damage, the person starts to have blurry, an attempt to illustrate. This is an attempt to illustrate the way glaucoma damage progresses. And so the picture on the far left shows a normal eye. You can see that butterfly beautifully perched on a flower. This could be normal or could be early glaucoma. So a person with very early glaucoma could see this well. The picture on the far left, but the person already has glaucoma, but the damage is not enough to notice it yet. In the second picture, you can see there's a significant, that's what I mean by the field. You can no longer see to the sides. So this person is beginning to develop a constricted field. So you can see that they can't see wide outside that butterfly. And it continues to progress until you have what we call tunnel vision. And so the picture on the far right, essentially this person has gone blind. It doesn't matter how sharply he can see centrally, he can't see to the sides. That person will find it difficult to walk, from point to point. And this is how glaucoma damage progresses. Now, to treat glaucoma, it's aimed at reducing the eye pressure, because eye pressure is still the best recognized risk factor for glaucoma, etiology. Therefore, if you want to attack a problem, you've got to reduce that eye pressure to a point where it slows down the damage to the nerve. Now, the damage may not stop completely, but it can slow down. Without treatment, a person may lose 20 to 25% of that field and vision every year, which means give or take 4 to 5 to maybe max 6 years, this man will go totally blind. Whereas you can significantly reduce that damage, maybe 2, 3, 4%, with treatment. And so it's very important. Treatment is aimed at reducing the pressure. And the modalities of treatment will differ depending on the ophthalmologist. This is not the forum to discuss the pros and cons of the various modalities. Every treatment regime is individualized to suit the person, what's best for that person. It can be medical with eye drops, it can be laser therapy, it can be surgery, or it can be a combination of any of these. So the ophthalmologist is in the best position to sit with you, discuss with you, and decide what will work best for you. Now, if we talk about treatment success with glaucoma, success with treatment is very dependent on how early your diagnosis is made. So naturally, late diagnosis gives less chance of success, because success means for you to keep reasonable vision, field, and acuity for your lifespan. And so if you already have a lot of damage, then it's an uphill task, and success might not be assured in this case. And also how well the pressure is reduced. And so I've told you that treatment is aimed at reducing eye pressure with whatever modality. Now, if normally it's a sort of experimentation in the beginning, because you have a fresh patient, you get an eye drop, use the eye drop, you come back for a pressure check, and we compare what pressure you have with what pressure you started with. We have a target pressure. If you meet the target pressure on the one medication, good, you continue on it. If you do not, then you might have to have extra medications. There's a total number of medications you can be on that is taken to be the max. And if, in spite of the max, you're not making good pressure control, then you might have to augment with something else, perhaps a surgery, and then still continue on drugs. And like I said, these things are highly individualized and depends on the peculiar patient and all of that. And so it's not one size fits all. It has to be individualized. But the lower your pressure can be, the better your chances of success with treatment. Consistency of therapy, absolutely important. I have patients who use the drops do the job, but they don't remember all the time. And therefore, this affects therapy, because every time you forget your drop, your pressure spikes and it leaves a little more damage. And so if you're not consistent with compliance, then there's a problem there, because it affects the chances of success as well. When you have other diseases coexisting with glaucoma, any other vascular diseases, entities like hypertension, diabetes, they kind of worsen the chance, because they already compromise your nerve, because in and of themselves, they are diseases that compromise your blood flow. And so then you have glaucoma on top of it. So they naturally go with, worse prognosis, especially if you're diabetic, because diabetes in itself can give you a separate set of retinopathies, which means, retinal complications that can in themselves reduce your vision. Now let's talk about prevention. I get asked that very often. Can you prevent glaucoma? And I say to them, not the type that is hereditary. If it's a secondary glaucoma, which means there's a cause, if you can manage to avoid that cause, then you can avoid, developing glaucoma. So whatever, can help you with injury prevention, either at work, at home, or children at play, will reduce the incidence of glaucoma due to trauma, due to injury. If you proper eye medication when you have inflammation, so you don't end up with the complication of glaucoma, and then people should avoid abuse of steroids, because this can cause glaucoma. And if you have diabetes, you must control it properly. There's a genetic link between diabetes and glaucoma. A lot of people who have diabetes will develop glaucoma. not necessarily 100%, but there's a high chance. And in the same vein, a lot of people who have glaucoma, if you follow up their glucose, thresholds, you find out that they're either at that pre-diabetic level or at some point they might actually cross into diabetes. It's actually a genetic link between the two disorders. It's important to know that the commonest variety of glaucoma has no known preventive measures. That's a matter for destiny, I'm afraid. If you're going to get glaucoma, you will have glaucoma. There's no way to prevent that primary hereditary glaucoma. However, there's a distinct difference between glaucoma and glaucoma blindness. And so there are lots of patients I have who have been treating glaucoma for a decade and a half, too. They still have good vision because they discovered early and they have prompt and consistent treatment. So you can have glaucoma. You don't have to go blind from it. So prevention of blindness from glaucoma is what we should be talking about for those who have been diagnosed with glaucoma. Regular eye checks, including glaucoma screening. So it's not enough for you to go and change your spectacles without having your nerve looked at and your eye pressure measured. So that if there's any suspicion, you can be referred to the ophthalmologist. I'm sure most people get to the optician or the optometrist to change their glasses. You will need to see an ophthalmologist if you have a glaucoma, a suspicion of glaucoma. And so annual checks, very important. Ideally, it should be every 6 months, especially if you have a risk factor. And we mentioned risk factors earlier. However, annual checks once a year, just get a clean bill that says you're fine. And so that's very important. Now, prompt commencement of therapy when prescribed, because we have a lot of patients in denial. And so patients come in and then we tell them, oh, I'm afraid you've got glaucoma. And they say, no, or I reject it, or some other, phrase. So when people are in denial, it leads to a delay in commencement of therapy. Sometimes, unfortunately, the denial starts at a time when treatment is most valuable, when they don't have any symptoms. Later on, when they've got 60-70% damage, they come back when they notice that the vision is blurry. Unfortunately, at that point, it's an uphill task from then on. So it's important to accept. If you're not sure, get a second opinion. It's legal in medicine. Go somewhere else, get a second and even a third opinion. Convince yourself very quickly and then start your treatment. Consistent maintenance of therapy is important. Like I said, if you keep missing your drops or forgetting to use them, then you're not going to have good control, and then chances of preventing blindness will be dim. Regular follow-up at the ophthalmologist are, very important. So it's not enough that you're on therapy. You've got to keep reassuring yourself it's working. That's because sometimes you can have what you call tolerance. A drop can start working in a fantastic manner, and then some months or years down the line, it just apparently loses effect. This can happen with any sort of medication, not just glaucoma medication. And so you'll find that you need to know what your pressure is doing from time to time. And so you know that you cannot judge how high your pressure is by how you feel in the eye. I have consistently said eye pressure is painless. Glaucoma is painless most of the time. And so whether your pressure is 10, 20, or 50, your eyes feel the same way. So it's important to realize this and know that you've got to have the only way to know what your pressure is doing is to get an objective check at the ophthalmologist. And this is very important. Regular glaucoma screening for any blood relatives. I've said time and time again, it's hereditary in nature. And therefore, if you have glaucoma, the message is spread the gist to everyone in your family. They should be checking their eyes regularly. So let me summarize by saying that glaucoma is the world's leading cause of irreversible blindness, and it occurs because there's high pressure in the eye damaging the nerve. It is largely painless, and blurring only becomes obvious after you've already lost up to 70% of your nerve. And blindness can occur within 5-6 years for a person not on treatment. It's important to detect it early, and effective and consistent treatment gives the best chance to avoid blindness. You should check regularly or at least annually. And so I urge you all, don't join the statistics, get your eyes screened today and regularly thereafter. I thank the Salam sisters again for having me. I pray that Allah's Rahman never leaves us, even for a blink of an eye. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum.
Wa alaikum salam wa rahmatullah wa barakatuh.
There's some technical issue here. 1 minute. Right. Now still. Okay. Assalamu alaikum. Well, thanks very much, Dr. Alimi. See, this is where it's very important that when we invite people, we have people who really know what they are talking about. That was an in-depth analysis of the disease. Thank you very much, Dr. Alimi, for sharing with us. We really enjoy every single bit of it. Now, I will now call on my co-moderator, Sister Yetunde, to give us a summary of the key points. She is, mashallah, really good with doing that. Most of the lectures that we do run from Salam Sisters. Sister Yetunde usually give us she calls it gems from the lecture. So Sister Yetunde, over to you.
Mashallah. Assalamu alaikum. Thank you so much, Dr. Alimi, for this precise, up to the point, direct, easy to digest, and information. And basically, from all that you've said, I mean, this is the very first time that I've learned that glaucoma is not something that we should toy with by just visual inspection, or the way you feel may not just tell you that you have this ailment, and it's important to get the eyes screened specifically, and the sooner the better, and it should be periodic. And if that's, I want to believe that that is very important, to have periodic eye checks. There's always an imprint of our forefathers in each one of us. And that imprint, we may not be aware of where, if we have that print in us. So any of us could come up with that ailment. So it's important for us to have our eyes checked periodically. Age is no respecter of the disease, of this ailment as well. And any time that we come up with any challenge with the eyesight, it's better we go to the specialist. And of course, once we start treatment, it's important to also make sure that one continues with the prescription or the medication that has been prescribed. And of course, minding what we ingest in terms of steroids and all of those things. I think it's something that we all need to be mindful of. And we need to be observant as well, so that it doesn't get to a stage where it cannot be treated before one knows what to do. So the sooner, the better. And that's very important. Thank you so much, Dr. Alimi. And so we will then just jump right into the QA session. I think the questions are coming in quickly. And so that's the next phase of the lecture. Thank you so much, Dr. Alimi.
Alhamdulillah, you're welcome.
Jazakallah khair. Thank you so much from me as well. That was very, very insightful to know. As someone who is, I guess, still growing, and these are good things to know and to keep in mind, so that if me or anyone in my generation, shows any symptoms, I am in a better space to advise them to people who are as knowledgeable as you. So Jazakallah khair, thank you so much. I'm going to be running the question and answer session, and I'm just looking into the chat. Please, everyone, feel free to raise your hand if you would like to ask a question, or type the question into the chat box. I'm already seeing a lot of people also being very appreciative of this lecture that we've had today. We've had several people say it was very informative, very precise. May Allah reward you abundantly. Jazakallah khair. The first question is, what is the normal eye pressure? That's the first question we have in the chat box.
Okay. Do you want me to go ahead and answer this right away, or do we want to take all the questions? Should I just go ahead and answer?
Go ahead and answer this right away, please. And then
Okay, that's fine. More. Okay, thank you for that. Normally, in numerical terms, the textbook, and I'll tell you why I said textbook, the textbook figure is 10 to 20, and pressure is measured in millimeters of mercury. 10 and 20, that's a range. However, in the past, we thought it was strictly about keeping within this range. Now we know better. We understand that people have different thresholds beyond which it affects the circulation of their nerve. And so, generally speaking, yes, we want you to keep between 10 and 20, but we know that 15 and less works best. The lower the pressure, the better. But we also know that people have different thresholds, by which I mean a person might have 21, 22, 23, seemingly above the normal limit, but when you test them, there are other tests we can carry out and to tell us if this pressure is actually affecting the nerve. We find out they're free, there's no problem. However, a person can have pressure 16, 17, and yet they have glaucoma. And so that's why I said it's textbook. That glaucoma is a disease that has kept emerging. It's still ill understood, even by the practitioners, I'll tell you. There are different entities, different explanations for why things happening and why things don't happen. So we've discovered that some people can have seemingly normal range of pressure, and yet they're having glaucoma. And you can have slightly over the limit, and you're still fine. So it's not enough to have just the pressure check. When you have a glaucoma screening, there's a set of tests. Pressure is just one of them. We need to look and see what the nerve looks like. We need to run what we call the field test, a visual field test, to tell us if anything is damaged. And so that's the general range, 10 to 20, but the threshold for each person, what's good, what's optimal, differs per person. Thank you. I hope this answers the question.
Thank you. Thank you very much, Dr. Alimi, for that clear response. I believe that answers the question. The question on the chat, or rather there's a hand raised, and it's Saada, but I see now that she's posted the question on the chat box. The question goes, does the new artificial cornea transplant restore sight of a glaucoma patient? So that's a question, except she wants to clarify further.
Okay, so I can go ahead and take this. Thank you for your question, Zada. Right, now, no, it doesn't, because, if you remember, one of the diagrams that I used for illustration, I had a section of an eye, and you saw pressure working backwards and starving the nerve of its blood supply. That is the cause of glaucoma. That is what directly leads to glaucoma. The cornea is the front part of the eye. When you look at any person, it looks dark. That dark circle in front is actually not dark. If you shine a torch on an eye and you look at the person, you'll find that you're looking through a transparent mirror at a brown membrane in the eye. It's that brown membrane, our iris, that gives the impression, makes the eye look like it's black. And in the Caucasians, their iris are of different colors, blue, green, amber. And so that reflects gray when you look at them from the outside. But it's actually a transparent layer in front called the cornea. If you have a scar on the cornea, you may be able to benefit from a transplant with a clear cornea, but that will not influence a glaucoma, because the glaucoma, what's happening is happening elsewhere, absolutely. Cornea is in front, the glaucoma is the nerve at the back. And so if you have a glaucoma, a corneal transplant will not get rid of the glaucoma. However, if you have coexisting a glaucoma and a corneal scar, and the corneal scar is significantly impeding your vision, yes, a corneal transplant will then help you with some increment in vision, but not by influencing the glaucoma. The glaucoma doesn't go away. It's there for life. And that's the other thing that I think I didn't mention, which I need to say now, that glaucoma doesn't go away. Treatment is control. If you stop treatment, it starts to damage again. So when you're on treatment for glaucoma, it's lifelong, I'm afraid. But that's the reality. Thank you for the question.
Okay, thank you very much,
that clarification.
Yeah. Okay, go on, Sister Yetunde.
Yes, please. Thank you. Thank you so much for that clarification. And thank you so much, Sada, for asking that question. because the question did a lot to also address another issue that was not discussed. Thank you so much. We appreciate that question. And so over to you, Rahma. Could you take the next question, please? We'll take one more question before we attend to the other hand we have in the chat box. Sis Amina, just a moment. Hold on a second, please.
Would you like me to wait or read the question in the chat box?
Go ahead, Rahma. Thank you.
All right, thank you very much. So the next question in the chat box is, oh, there's several, so I'm just going to have to scroll down. Does the new artificial cornea transplant restore sight of a glaucoma patient? I believe, is that the one that we've just answered now?
We just answered that, yes.
There's another one further down from Ayala Tawakkalt.
Okay, yes. What are the symptoms, or should I say signs, to look out for when it comes to glaucoma?
Okay, so thank you for asking that, so that I can re-emphasize that in the beginning, you have absolutely no symptom, nothing. Your vision looks nice and sharp. So a lot of people walking around thinking they have good vision already have glaucoma, but they don't know it yet. The first symptom is blurry vision. And at that point, 70% of your nerve, or almost, already destroyed. And so that's not the stage to be finding out that you have glaucoma. So it's which is why we've tagged this the silent vision extinguisher, or the sneak thief of sight, because when 70% is gone, the most useful part of your vision is gone. And so I need to impress on everyone, if you don't take anything out of this presentation, please know that the fact that you can see sharply doesn't mean you can't have glaucoma. There are no symptoms in the beginning. First set of symptoms, blurry vision, after up to 70% is gone. And so please check your eyes, because you might see sharply and still have glaucoma. Thank you. I think that answers that.
Subhanallah. Thank you so much. And that actually makes it kind of scary now that you say it again, to say that you can even see well what may be coming up with this ailment. May Allah give us good vision. Ajia Amina, you raised your hand earlier. Would you still have a question, please? Bismillah. Dr. Salihu, please. Okay, looks to me like Dr. Amina Salihu, she's put her hand down now, and so we can, oh, you can't seem to unmute. Okay, I'll just unmute you.
I think she's posted a question on the chat box, so if Rama would like to read it. She can't unmute. Can we take Rauda, our Turkey director?
Assalamu alaikum. Please, my question is that. Please, my question is that for someone detected of glaucoma with they prescribe a glasses, lens, and eye drop. So after being using it, I did not see any symptoms of. I'm not seeing any symptoms. Should we continue the eye drop? Are we to continue, or after it's finished, we are going to stop and go for another eye test? Or what's your advice on that, sir?
Okay.
Because the eye drop we're giving is ivizozole and betazole.
All right.
So I've been using it since. Yes, I've been using it since. But it's hereditary because me and one of my junior sisters, we are detected of it. So after using it and we don't see anything, can we just stop?
Okay, thank you. Thank you for the question. Okay, now again, like I said, with glaucoma, we never get tired of saying it over and over again, because sometimes repetition helps it to stick better. Like I said, it's lifelong treatment. You do not stop treatment. If you stop treatment, you see, try and understand, there's a difference between a cure and a control. Let's say, for instance, a person has a boil. You have a boil somewhere, it's painful, and then you take an antibiotic and then it's gone. It's gone. That's a cure. You might have a boil another time, but that will have to be another time. At that point in time, that was a cure. However, if you have, say, hypertension, you take your medication and your blood pressure comes down, it reduces, you stop your medication, it's going to go back up again. So that's the difference. That's control. And so with therapy, you're controlling this disease. But to achieve success, you've got to keep the control going. And it's the same thing with glaucoma. If you have cataracts and you have cataract surgery, that's a cure. It's gone. The cataract never comes back. But glaucoma, it's a piece of flesh you can't change. It's sitting there and the conditions that made it bad are still there. And so your eye pressure drops will reduce the pressure. The moment you stop using the drops, pressure comes back. And so typically, if we want to know if a patient is doing well on drops, you have to have used even that morning's dose before coming to the clinic. And so oftentimes people come to the clinic and say, oh, I forgot, I didn't use it this morning, but I did use yesterday evening. I tell them, you're not eligible to check your pressure. We're not going to get the information we need. We need to know if you're using a twice daily drop, you can't even have missed that morning's dose. So that's how closely you need to follow up your therapy. So if you're on a drug, you've got to continue using your drug. If your drug is running out before your appointment to the doctor, get more and keep using the drug. And you get to see the doctor, he checks your pressure, let the doctor decide if they want to switch you to something else or if they're happy for you to continue. Now, you're not going to see a difference in your vision. Let me quickly say something. When a person has had glaucoma damage, they have blurring. And a lot of the time, even though we tell patients that they're not going to see a difference in the vision, what damage is already damaged. What you're trying to do, the point from which you start therapy, is to stop more damage from happening. That's what it is. It can always get worse. It can always get worse. If you've lost 60%, you can go on and lose 80%. That's a worse situation. And so let me emphasize that treatment is not supposed to make your vision clearer. It's to stop what you have, stop you from losing what you have left. And so if you're using drops, don't say, oh, this vision isn't clearing up, and you stop your drops. It's going to get worse. And so that's what I need to impress on you. If you're a spectacle user, especially if you're short-sighted, and you get a pair of spectacles, that will help you see better, because that's its own contribution to your blurring. The glaucoma doesn't go away. It doesn't take away what the glaucoma does, which is the cloudiness. And so a patient might say, yes, with my glasses, I can see better, but I still have that sort of cloudy quality to the vision. There's no taking that away. That's the glaucoma. But don't stop your therapy. Therapy is lifelong. It's for the rest of your life. It's lifelong. You don't stop. It can only be modified at some point. I hope this answers the question.
Yes, ma'am. I would like to ask that. Assalamu alaikum.
Wa alaikum salam.
Yeah, I would like to ask that. Is there any food because I browse it online that sometimes they go that glaucoma with food, what we eat, that they are both working on the same. I don't know, maybe there are some diets we have to.
No. There really isn't any special diet for glaucoma. The sort of things we like people to avoid are things we know are toxic to the nerve: smoking, alcohol. Okay. Those two especially. So if you don't smoke, and you don't take alcohol, if a person is there are certain medications that might be toxic to the nerve. And typically, if a doctor is going to start you on such medications, they will ask you to go have an eye check, a basic eye check. And then subsequently, they might have you do it at intervals, just to be sure that this drug you're using isn't damaging your nerve. But that's not going to cause glaucoma. And so there's no known diet that predisposes you to glaucoma. But we know we want people to avoid negative lifestyle habits like alcohol and smoking. And we know we want to advise you to eat lots of fresh fruits and vegetables, just because these are brimming full of the sort of micronutrients, vitamins, and minerals that are generally good for the body's cells, the body's work, including the nerve. So it'll help to strengthen your nerve. That will probably play a role in sort of resisting damage. For whatever it's worth, we tell people to eat a diet good in fruits and vegetables. But there's no particular thing you need to avoid, but lifestyle changes. Smoking, alcohol, out the window.
Okay, Jazakumullah khairan, ma. Thank you very much, ma'am. Okay, yes, ma'am.
Over to you now, Sister Here today.
Thank you very much, Miriam, for your question. And it appears that your question has addressed another question that we had on the chat box earlier. One of our sisters was asking if there was a lifestyle that would support or aid in one not getting this ailment. So it will, I mean, can you shed a bit of light on that? Because yes, she was asking about diet, but then another sister is asking about lifestyle. So I think it's also connected. And I think you've also addressed that to say no smoking and all of those things as well. So I think that takes care of that. Rahma, next over to you, please. Thank you very much, Dr. Alimi.
You're welcome.
Thank you very much. Thank you, Sister.
I believe everybody, just 1 minute, Rama. I believe everybody who would like to ask questions should be able to do so now. We've asked our technical director, Rhoda, to unmute everybody. So if Dr. Amina is still there, you would like to ask a question, please, or that's been addressed? Yeah, it has been addressed. So if you like to ask questions, please put up your hand and Sister Yukino will be happy to call you. And if you have questions you would like us to ask for you, type in the chat box and Rahma will be more than happy to let the doctor know about your questions. Thank you.
I think I can see a question that says, to recap the association between diabetes and glaucoma.
I was going to ask that question as well. Yes, please, please go ahead.
Yeah, so, so I started by saying that it's been discovered that there's actually a genetic link between diabetes and glaucoma. A causation of diseases generally, you can mostly, with gene sequencing, you can actually locate it to what gene in the body is involved with a certain disease. And the first chromosome, chromosome 1, is the locus for glaucoma. And it's, as it so happens, the same chromosome 1 is also the locus for diabetes. And so there's a link between the two diseases. And so we find that a lot of people who have glaucoma, if they're not diabetic, when you check their blood sugar, you find out that it's around that high end of the range. And at a certain point in life, they might actually cross over into glaucoma, into diabetes, I beg your pardon. And then, also, if you have patients who are diabetic, their eye pressure tends to be a little on the high side. And at a certain point, if you can prove that that pressure is damaging the nerve, then you diagnose them as glaucoma. So I'm not necessarily saying that one will definitely lead to the other, but we've definitely seen that link in many patients. This aside, diabetes as a disease can cause what we call diabetic retinopathy, which means that it causes a problem with vessels leaking at the back of the eye and causing, hemorrhaging, bleeding at the back of the eye, causing edema, swelling at the back of the eye. All of this can lead to reduced vision, even if you didn't have glaucoma. And so that's why I'm saying that even diabetes on its own can cause eye problems. And so if a person is diabetic and is compounded by glaucoma, that's double jeopardy. That's what I meant. And then when you start having lots of blood vessels forming in the eye, abnormal blood vessels from diabetes, if you have those vessels crowding the eye, that can cause a refractory kind of glaucoma that's not even amenable to treatment with drugs. That sort of glaucoma doesn't even respond. It needs a special, different kind of surgical procedure. And so, yes, there's all sorts of ways that glaucoma and diabetes can link, but I'll also go ahead and tell you that there are many diabetics who don't have glaucoma, and there are many with glaucoma who do not go ahead to get diabetic. Again, there are many complex factors interplaying with each other. So that's the much that I can say about that.
I believe that is well explained. Over to you now, Sister Yetunde.
Thank you very much. There is, okay, so I was gonna take a question from someone with the ID LG Stylo 5. You'll have your hand up. Please unmute yourself and ask your question.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
My question is, I've been on eye drop for some years now, but it makes my eyes to be red. I complained to the doctor, that's part of the what's it called? That's one of the things I've been seeing on my eyes that makes my eyes to be red. That's the retinopathy. So what can I do, ma'am?
Right. Okay. latanoprost is a very good drug. As a matter of fact, it belongs to what we consider right now to be the best class of drugs for treating glaucoma. But that's the one effect it can have. It can make your eyes red. Now, a lot of doctors would consider many factors when they place you on glaucoma. I beg your pardon, on the latanoprost and related drugs. The reason why it's first-line treatment is because it's so convenient. It's just a once-a-day drug. Because when you have a person on treatment for the rest of their lives, it matters how much inconvenience that's going to give them. And so if you have a drug you have to use 3-4 times a day, it's going to affect compliance. They're only human. They're going to be missing doses. And so if you have a drug that's so good that once a day it does the job, and nighttime, bedtime. And so that's so convenient. You don't have to remember before you go to work. You don't have to remember in the middle of work. Once you're going to bed, if it's by your nightstand, you can just put it in and you've used your drug. That's very convenient. Unfortunately, it does cause redness. Now, the doctor would gauge a lot of factors before taking you off the drug. If your eyes are red and painful or itchy, it means you are hypersensitive to the drug. They'll have to take you off it. But if it's just that red coloration, and that red coloration doesn't give you any symptoms, you're not uncomfortable, the eyes don't feel congested, nothing, he might opt to put you on it because he sees that it's doing a fantastic job and that is the best drug for you. However, if you're very concerned about the redness, and in a lot of patients, that redness is temporary. After a while, it kind of fades. So even if it's red, it's very slight tinge. And so you might choose to go ahead and continue using it. For those who are very sensitive about remarks, people pointing things out, you may be forced to change them to another drug. But this is a drug, whatever you're changing to, that's the only class of drugs that give you the opportunity to be used once a day. Whatever you're switching to has to be 2-3 times a day. That's much more inconvenient. They may not be as effective. And so you need to sort of have that conversation with your doctor to decide, can you really stick with it? If it's uncomfortable for you, either physically or psychologically, your doctor should take you off it. But if it's I have patients who have a very slight tinge of redness and they opt to keep it. They say, listen, is it just a redness? It's just skin deep, as they say. It's not wreaking any havoc on my eye. And I say, no, it's not. They leave it because this person has pressure, 29, 30? And with this drug, it tumbles to 14. Fantastic response. And so they decide to stay with that drug. So it's a highly individualized decision. You need to have that interaction with your doctor to decide if you really should stay on it. If you really don't want to, you have a right to say, please change the drug. I don't mind using another drug twice a day. And then it's now your responsibility to make sure that you're very consistent with the use. So those are the issues. You'll have to have a good talk with your eye doctor.
Thanks so much, I appreciate it.
You're welcome.
Thank you. Now, there are more questions on the chat box. Rahma, could you take the next question on the chat box, please?
No problem. So I'll just scroll through and have a look. Right, so another question on the chat box is, what are some preventative eye drops one can use? Can you advise what kind of diet or lifestyle may keep glaucoma at bay?
Okay, we already addressed diet and lifestyle, I think. There are no preventive eye drops, absolutely none, to prevent glaucoma. None. So, what we need is to check on the pressure and have a proper screening. So you know at what point, if your eye pressure gets to a point where it's disturbing the nerves health, then you start eye drops. But there are no preventive eye drops at all.
Thank you very much. And I hope that answers the question to the person that posed it. Are we taking another question from a hand raise or more from the chat box?
Go ahead and take the next question in the chat box, please.
Okay, so another question is, and I don't know if this has already been asked or addressed, could having a cloudy or constant wet eyes be glaucoma? What is the difference between glaucoma and cataracts? Hope I called that properly.
Probably cataract.
It meant cataract, yes.
A cataract.
Well, there are things you call differential diagnosis, which means if you take a particular symptom, there are 10, 20 more things that can possibly give you those symptoms. So it's difficult to evaluate cloudy vision right here on the screen. Cloudy vision can be from cataract, it can be from glaucoma, it can be from an allergy if you scratch your eyes a lot, it can be from an inflammation in the eye, it can be from having a refractive error such as being myopic or hyperopic or presbyopic. There are lots of things that can cause cloudiness. And so it's not possible for me to definitely tell you that if you have cloudy eyes, that it's a glaucoma, but I'll tell you that cloudiness can be a symptom of glaucoma when there's already been some damage. So these things will have to be properly checked out at the eye doctors. If your eyes are constantly wet, it could mean that you have dry eye. Now that sounds funny. The eyes are wet, you have dry eye. That's because normally the lubricating mechanism of the eye is such that there are certain layers on the eye that help the tears to stick on. So there's a basic amount of wetting that the eyes have. When you lack this stick-on factor, the eyes are actually dry, and there's a mechanism that feeds back to the brain to tell the brain these eyes are dry. And so the brain orders the major gland sitting right there to produce water. And so that's why the eyes are constantly wet, because the basic wetness is missing, it's defective. And so the eye is watering because the bigger gland, which shouldn't be the one, it only comes into play when you have either irritations or emotions, when you're crying. And so that now comes into play to attempt to compensate for the little ones on the surface that are defective. And that's why I said if your eyes are wet all the time, it could be a symptom of dry eye. And that's one. Also, especially as we get older, some people's eyes can be wet all the time because there is a blockage. There's a tiny little opening at the edge. If you do this and you have someone shine a torch, you will see a tiny little hole in the corner. That drains any excess fluids from your eye into your nose. And that's the explanation. Anyone who's ever used chloramphenicol eye drop will know that a few minutes after using the drops, you taste the bitterness in your throat. How did it get there? That's because it drains through that punctum into your nose. And when you take a breath, it sprays to the back of your throat. That's why you have that bitterness. The hole is the other reason why a person who previously didn't have a cold starts to sniff and blow their nose when they're crying. Because excess, apart from the tears coursing down the face, a good deal of the tears, amount of the tears is draining into the nose and mixing with the mucus in the nose and giving off the impression. That's why people who cry actually blow their nose. It's the excess tears mixing up with mucus. And so as we get older, some people have a blockage of that punctum. And therefore, normal excess fluids that normally will be draining, and so nothing begins to course over the cheeks. Also in pediatric patients, a lot of us are born with that duct not yet open. Most babies are born with the ducts not yet open. But then again, most babies don't have glands that work yet. The gland that produces water doesn't work yet. That's why they're not constantly streaming. But by the time the baby gets about 3 months, when that gland really starts to work, such babies with blockages will start to have that water, always having watering in the eye. So these are all different entities. And that's why I say to you that it's difficult to evaluate right here. You have to have an evaluation at the doctors to tell what exactly is going on, why the eyes are watery. And as for the difference between cataract and glaucoma, absolutely different. They couldn't be more different. We all have a lens in our eye. We have something like that, like the lens of a leg, but in our eyes, and that helps us focus rays onto the back of the eye. So when your lens is not able to focus the rays to the back of the eye because it's gone cloudy, it's no longer crystal clear like glass should be, then that's what you call a cataract. And it doesn't matter whether it's a tiny speck or whether it has spread and covered the whole of the lens, because the lens is shaped like that. It's like an egg, shaped like an egg, And so the dot starts, the cloudiness, like cotton wool, starts from a point and it starts to spread around slowly. And so the person might have blurry vision, but can still see. When it covers everywhere, then the person can't see. That's a cataract. And that's why I say to you, it's treatable. Because if we go and wash off that white cotton woolly thing, and replace with a clear artificial lens, your vision comes back. But glaucoma is completely different. It's a piece of flesh at the back of the eye. There's a nerve that connects your eyeball to your brain and takes visual messages back and forth. It doesn't matter how fantastic your focus mechanism is. Once that nerve isn't functioning, you can't see a thing. And that's glaucoma. So when pressure affects the back of the eye, affects the nerve at the back of the eye, it's blood circulation and it can't function, that's what you call it glaucoma. But when, as a result of aging or some other factors, you have a cloudiness in the lens of your eye, the natural lens of your eye, that's a cataract. They're two different things. One causes reversible blindness, one causes irreversible blindness.
Thank you very much, Doctor. And it's actually interesting that you've just mentioned about dry eyes, because there is a connected question in the chat box here. And I just thought I need to mention that if there's anything more you need to add to that. And the question is, can untreated dry eyes lead to glaucoma? Or what is the long-term impact of having dry eyes?
Right, so the answer is no. Dry eye doesn't lead to glaucoma. So no, definitely no. Now, when you have dry eyes, it's uncomfortable. That's basically what happens with dry eyes. It's very uncomfortable because normally your eyeball is lubricated. And that's the reason why when you blink, you do not feel the presence of the eyeball because there's a film of fluid that forms an interface between your eyeball and your eyelid. So your eyelid is smoothly blinking over the eyeball. You feel no friction. But when you have dry eye, there's a reduction in that layer of fluid. So there's like a closer relationship between your eyelid and your eyeball when you blink. And it can be so bad that the eyeball is literally like scraping over the eyelid. That's like sandpapering something. That's very uncomfortable. There are very sensitive nerves on the surface of this, what you see as the black part of the eye. You can just carry out, you know, a small experiment on your own. Wash your hands, very clean hands. Try touching the white part of your eye. You will. Try the black. Try touching this black part of your eye. You will not be able to do that because it's got nerve endings just sitting on the surface. And it's very sensitive to anything that irritates it. And so when you don't have enough fluid lubricating your eyeball or as an interface between your eyeball and your lid, every time you blink, you feel very uncomfortable. And so people describe all sorts of sensations. It can be peppery. It can feel like you're in a smoky room. So it's, you know, it's peppery, or it can feel like very uncomfortable with air currents. Like if you're sat where there's the, you know, current coming off an AC or a fan, it can be very uncomfortable. Sometimes, because I have dry eye as well, you can wake up in the middle of the night and it's just so hard to open your eyes. It feels, you're making so much effort. It feels very uncomfortable. And so that's why you get lubricants. They're very common. So ocular lubricants are things you can get by the gallons, if you like, over the counter. You don't need a prescription for it because it's quite common and it's bland. So it's not causing any problems. You can use as much of it. So normally what you do is you have that much of dry eye, very uncomfortable. You just always have one in your handbag, one by your bedside. So if you wake up in the night and you find you're very uncomfortable, just put the drops like magic, instant relief. And so dry eye is a completely different kettle of fish. It doesn't cause glaucoma. Let me clarify that. But it can make you feel very uncomfortable because the eyelid crossing over a dry eyeball irritates the nerves on the surface. But just by using lubricants, that goes a long way. But you have to keep using the lubricants because once those glands, whose function it was to keep the eyeballs adequately lubricated, once their function has deteriorated, there's nothing you can do to really bring the function back. It's part and parcel of getting older. You know, alhamdulillah for long life, but there are consequences of getting older. And this is one of them, you know. And so you'll just have to continue using your lubricating eye drops. So I hope I answered the question.
Thank you. Thank you so much for the clarification, Dr. Alimi. I believe that you've answered that quite nicely. But then what just comes to mind that one of my sisters has just raised is that is there an interconnection with poor night vision and glaucoma? If you could answer that quickly, then we'll take one of the hands that has been up for so long. Omobola Afolabi, I know your hand has been up for a while. So Dr. Alimi, what would you like to do? You want to answer that quickly, or you want
Yes,
Omobola
please.
Afolabi to
Yes,
ask a question?
okay, maybe she should ask, since she's been hanging on for so long. I think we should let her
Great
ask.
stuff. Thank you. Thank you very much. Omobola Afolabi, could you please unmute yourself and ask your question? Thank you.
Thank you, Doctor. Thank you very much, Doctor. Allah will increase your knowledge. I have two questions, but you've answered one, the dryness of the eyes. The second one is, if somebody has a floater, a small thing in the eyes, can that one lead to glaucoma? That's my question.
All right, thank you for the question. No, ma'am. Floaters are, as we say, they're shadows that you can see moving around, floating around. Sometimes you see them, sometimes you don't. At the back of our eyes, there's a gel. We all have this, when we're young, that gel is really thick. It is of the consistency of toothpaste, really thick. Now, as we get older, at a certain point in our lives, that gel begins to change. Just because we're getting older, it starts to get liquid. And as it gets liquid, some strands condense out of the liquid and they start floating around. And because it's liquidy, it now allows the strands to float. When it was nice and solid, even if there were strands there, the strands would be in one position, you wouldn't see it. And now because the strands are floating in now the liquid medium at the back of the eye, it floats into your view sometimes, floats out of your view sometimes. So that's completely different from glaucoma. It does not cause glaucoma. It is not the cause, and that's not a symptom of glaucoma. That's something everyone, if they're observant enough, will see at a certain point in their lives. It has no connection with glaucoma. Thank you.
Okay. Thank you very much. And if somebody is having like webs in the eyes, what that means?
Did you say wet? Wet in the eye?
No, like spiders webs.
All right, those are still floaters. Those are still floaters. Floaters come in different shapes and sizes. Okay. So people will describe them sometimes like a spider web, or like a mosquito, or like a fly, just a dog, like a stork, all sorts of fancy descriptions, but it's still part of floaters.
Okay, anyway, as you said, as you get older, I'm 70. So maybe that's...
Yes, ma'am. You learn to ignore it, ma'am. It's of no consequence. Just ignore it. Okay. However, ma'am, let me just quickly add that if you have light flashes,
okay,
if you have flashing lights, when you take a photograph, the way the flash goes off, if you have that kind of sensation in association with the floater, get the eyes checked. Get the eyes checked. But a floater on its own is harmless.
Okay. Thank you very much.
You're welcome, ma'am.
Allah bless you. I increase your knowledge.
Amen.
I appreciate you. Thank you.
Amen.
Amen. Amen. Amen. Thank you so much, ma'am. Thank you very much for the question. And thank you so much, Dr. Alimi, Jazakallah Khairan, for the clarification. Amen. So Dr. Amina Sali, please, you have your hand up. Do you please go ahead and ask your question? Unmute yourself. Thank you.
Jazakumullah khairan, dear sisters and our resource person. Thank you for the insight. I have a couple questions. And the first is to ask you, what is the minimum, type or quantum of symptom that one should have, and you begin to race to go and see an ophthalmologist? What is the least aspect of a discomfort that you should have, so that one is not too late to begin to address this issue? The second is something anecdotal I've heard, and I want to know the science of it. Some people say that there's a certain demographic that is susceptible to glaucoma, maybe gender or race or age, and I want to know what the science of that is. Is that true? Is there a certain demographic that is much more susceptible to glaucoma? Thank you.
Okay. Right, so I'll start with the first one about what quantum, minimum quantum, should make you want to see. That I'm afraid for glaucoma, if we're talking about glaucoma, that doesn't apply at all, because I've repeatedly said that at the stage when treatment is likely to be most successful, the person is asymptomatic, no symptoms whatsoever. The vision looks nice and sharp. Let me just give you a bit of an analogy here. the nerve in our eyes, it's like taking 1.2 million threads, you know, your regular thread that you might use to stitch, do some stitch work. It's like taking 1.2 million threads and bunching them together. That's how the structure of the nerve is. The nerve consists of about 1.2 million neurons in a bundle. Now, if you had 1.2 million naira or pounds in the bank and you spend 10 naira every day, it will take a while for you to notice that your balance is running low. Same situation with glaucoma. Every hour of the day, every day, a certain number of the nerves are falling out of function, but it takes a while to notice. And it takes 60–70% of that damage for you to have your first symptom, the blurring. And so that's why I say to you that where glaucoma is concerned, you cannot wait to even have a symptom. You don't wait for glaucoma to show up, you go looking for it. That's the attitude with glaucoma. Go searching for glaucoma. Don't wait for it to show up, because when it does show up with your first symptom, you're already 60% down on that nerve's function. That's the trouble with glaucoma. And so in this instance, check your eyes when things are good. Once a year, just get a clean bill. And then your other question, yes, about demographics. Yes, so, you know, when I talked about risk factors, I mentioned race. And so glaucoma is more common, comes earlier, it's more aggressive, and therefore more blinding in people of Afro-Caribbean origin. Why that is the case, it hasn't been said. Why is it peculiar? You know, why is it so severe? It's not peculiar to that race, but it's more severe. Why does it run a more severe course? Honestly, science hasn't given an explanation for this. Now, the other thing that I might talk about with race is the other type of glaucoma. You know, I've kept saying the commonest type, the commonest type. There are less common types of glaucoma. There's a type of glaucoma called angle closure glaucoma. This happens because there's a particular relationship between the organelles, the parts of the eye inside that predispose the person to having high pressure. This is peculiar to the Orientals. And so you find this sort of glaucoma, angle closure, is commoner in people of the Far East. But it's directly known that that's because of the arrangement of the parts of the inside of their eyes. It's slightly different, the relationship. And so that is known. So you can give an explanation for that type of glaucoma. But otherwise, it's a little, other things might have, other entities might have explanations. So for instance, if we tell you it's commoner in diabetes, you can link it, you know. And if we tell you it's commoner in short-sighted people, probably the best explanation for that one is because when you're short-sighted, most of the time it's because you have a long eye. And when you have a long eye, the coats of your eye are thinner. Imagine you have two balloons and you just blow a little air into one and then really a lot of air into the second balloon. That first balloon with little air will have thicker walls, and the one with the the bigger balloon will have a thinner wall. And so the protection for the nerve, the protection for the blood circulation of the nerve is less when you have a long eye with thinner coats of the eye. It's more vulnerable to pressure. And so this one can explain, that's logical. But there are certain things that we still can't explain, you know, especially with the Black race, the Afro-Caribbean race. So I think that's the bit that I can say about that.
Dear resource person. Let me ask a final question about tigris fundus and glaucoma. Is there any relationship if one's already diagnosed as having tigris fundus?
Tigris fundus?
Yes.
And glaucoma. Tigris fundus will mostly happen because of degenerations, you know, so some sclerotic changes at the back of the eye. No, you might have that and have glaucoma or not. They're not directly related. They're not directly related.
Thank you.
Assalamu alaikum. I'll take one question from the chat, and the question that we have is sort of in relation to, I'm trying to just find where I've sent it to myself. Okay, here it is. So the question is, oh, it's gone again. There it is. What is the further effect of a cataract on the eye that has already been treated for glaucoma? So I don't know if you've already answered this, but that's the question. So can a cataract affect someone who already has glaucoma?
Well, yes, it can. And oftentimes you find people who have both coexisting, cataracts and glaucoma. So both of them are causes, they can both impede your vision. And so if you have a glaucoma and then you go ahead and develop a cataract, then they're both, now you have two reasons why your vision is blurry. It will get more blurry, yes. And so if the cataract gets to a point where it's visually significant, it can be operated upon so that you get that out of the equation. And so the person is left with a treated cataract and then now just the glaucoma alone again. And so it should amount to an increment in the vision because you've taken away what the cataract was contributing. Oftentimes we find that the cataracts are not visually significant, so the person has to be a little patient and bear with it until it gets to a certain point where, you know, it can then be operated on. But yes, they can coexist, and where they do, they're each contributing. We often find that the glaucoma is the major contributor. And so a patient might put you under pressure to do the cataract surgery, but their best advice to leave it alone because they might find that there's no increment in vision after that because it wasn't that significant. So it depends on the person, but yes, they can coexist. And when they do, they contribute. They each contribute their quota, oftentimes one more than the other.
Awesome. Thank you so much, Dr. Alimi, Jazakallah khair for the clarification. So I've got someone's hand raised up. It's been up for a while. Fausat Mudukwe Abiola, could you unmute yourself and go ahead and ask your question, please? Thank you.
Okay. Assalamu alaikum, doctor, and thank you. Yes, I've been going for my glaucoma for the past 3 years. But they always say the first time I went, they did the test, they say it's not too bad. They can't put me on any eye drops now. Then they gave me 6 months. After 6 months, I went last time. They said the left is the pressure one is 16, the other one is 22, that I'm still okay. Then they give me another 9 months appointment. But notwithstanding, I'm on a borderline of diabetes because I'm not any tablet on diabetes. I'm only because of the way food I eat, but I'm always okay. But why I'm worried is that the complication of glaucoma is always blurring me. When I started with my eye, they say it's dryness. I put on 0.5, all these Apomes, all this alkaline for the eye, for the lubricants. But at times when I put the eye drops, I notice floating. Like you said, I'm so happy with the lecture you gave us. God will bless you and your family and you keep you safe all the way because I'm very anxious. Any little thing, I'm panicking. So I'm just wondering, now my appointment won't be okay until October, but the glaucoma, I don't know what effect it's going to have. When they say one is 22, one is 16, I don't want to be questioning them, so that they won't say this woman is a difficult somebody. So I just want to know the implication of all this. Thank you. God bless you.
Okay, ma'am. Amen. Please, ma'am, may I ask whether you've had other tests apart from the pressure? Have you had a field test, CVF, central visual field?
I think they did about 3 tests that day, but that the only one I just got to know is that they say one is 22, one is 16.
Okay, hold on, ma'am. Have you had a test where you rest your chin on something and lights are coming and you're clicking when you see the lights?
Yes, I've done that.
Right, and you did that the last time and they saw the results and said everything was fine?
Yes, my doctor just wrote me that everything is fine, that they are giving me another 9 months now, unless I have emergency to see them.
Well, because that's the test that should tell if there's anything. But you might seek a second opinion if you're not sure. If you have doubts, you should seek a second. That's legal. Seek a second opinion from an ophthalmologist. Yes, I assume you're seeing an ophthalmologist?
Yes, and the specialist. So
an ophthalmologist. There are different people in eye care. It has to be an ophthalmologist.
Oh, yes. Okay, the people on the road is the ophthalmology that do the vision sight, yes?
Not necessarily. It's not about your role. It's about the qualification. It's about the qualification, ma'am. Okay. Ma'am, what you can do is, can I publish my number? Can you take my number and give me a call after this? Let me just allay your fears. Just give you a check So I can tell you whatever, you know, I find, because you're anxious.
God bless
and I
you.
fear that
God will
might
solve your
affect your
problem
health
for
in
you.
other ways. So what I'm going to do is I'll let Salam sister tell me if it's okay, or how I can pass my number to you, so you can just
All right.
for a second opinion, you know.
Okay.
Good
Thank you.
Tell me what to do.
Good, you mentioned that, Dr. Alimi. Actually, we were hoping that, yeah, we'll be able to share your details if you're happy to do that on the chat box for anyone who may want to contact you individually. But at the same time, we do encourage people to ask questions, but obviously there are limitations as to what Dr. Alimi will be able to do now. Obviously, she won't be able to make any diagnosis just by speaking virtually. So we will really appreciate if we just keep the question, something that she can really help us with. Yeah, you have a number on the chat box if you need a number, and possibly your email address as well, if you're happy to share.
Thank you, doctor.
You're welcome.
Okay, over to you, Sister Ayu today.
Thank you so much, Dr. Alimi, and thank you very much, Ma. Thank you very much, Ma, for the question. And inshallah, we will implore you to please keep your mind at rest. May Allah restore your health. And inshallah, Dr. Alimi has offered to take a look at your eyes for you. By the will of Allah, everything will be okay. So please do not be anxious. Allah's got you.
Amen.
Yes, ma'am. I've got hands on the chat, and that's for Aja Kudrat. Can you please unmute yourself and ask your question? Although, Dr. Alimi, there was a question I asked you earlier, so you are still owing me one question.
Okay,
so
maybe did I skip a question? You can ask again. Sorry.
There was a question that I asked that I said that there was a question around, is there an interconnection between poor night vision and glaucoma?
Okay.
Yes. And then
yes,
Ajia
that's right. I remember that. I remember that.
Yes.
Go ahead. Okay. The thing is that anything that reduces the acuity of your vision, you're likely to realize it first with night vision. That's because the natural illumination is down at night. In the daytime, the natural, lights helps us with our vision. That's why you'll see your book clearer if you are near a window versus if you're in a dark corner in a room. And so, yes, if a person has glaucoma that has significantly affected the nerve, it's going to affect their vision at night, because glaucoma darkens. You remember the illustrative picture I showed you in the presentation, how it just closes in and leaves the person with tunnel vision. Those outer areas are dark. They've left a dark spot called scotomata. Now, that is superimposed on the already dark evening, the dim illumination. And so, yes, if a person has glaucoma that is significant, it's going to affect their evening vision. The same way if you're just short-sighted, no glaucoma, again, in the evening, you will see less. So that's why I'm saying anything that reduces your vision, it will be accentuated at night. At night, it will be worse. So the answer is yes. If you have a glaucoma, you will see less well at night. Yes. Okay, I think I still have other questions. Hands raised.
Yes, you do. Ajia Kudrat is going to unmute herself and ask her question. And then after her, we'll take Alaji Ushua. Please, Bismillah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakallah khairan, Dr. Alimi, for educating us today on this fundamental topic of how to care for our eyes. My question is, and before I ask my question, I will ask a question related to the last question, which you just answered. Are you trying to say that having night vision, poor night vision, is a sign of having a glaucoma? Because I think that question is asking about somebody who is not aware that they have glaucoma, but they have poor night vision. So is that a sign that they may develop this glaucoma?
If you have, not necessarily, no.
Okay.
Now, let me make a statement and say that if you have a significant glaucoma, your vision will be poor at night. But let me also say that poor night vision is not necessarily indicative of just glaucoma. A person can have poor night vision because they're short-sighted. They're not wearing glasses. And so they manage to see a certain detail afar, daytime, nighttime. The natural illumination is down. They're not going to be able to see it.
Right.
Now, there are people who have retinal diseases. One on the list, top on the list, I might give you poor night vision, is retinitis pigmentosa. It's a long name. It's a genetic disease. That person does not have glaucoma. It's just a retinitis. But as a result of the retinitis, they can't see at night. And it can happen even in children. And so sometimes you can have a situation where a parent will come and say, this child, once it's evening, they don't go out. One of the things that can cause this is the retinitis. It could also be a child who can't see afar. It can be a short-sighted child. And that's why I'm telling you that poor night vision is not characteristic of glaucoma. But if you do have glaucoma, it can be one of your symptoms. But it's not pathognomonic, if we may put it that way. It's not, associated with glaucoma as a unique entity. That's what I'm saying.
So, Marshall, thank you very much for putting an insight into that. Now to my question. Is there a risk of developing glaucoma if you suffer from migraine? And I mean migraine with the one that comes with flashing light, the aura. Is there any relationship with that and glaucoma?
Not necessarily, no. There's no established relationship between migraine and glaucoma. None.
This migraine, from what I was informed, it causes blindness to the back of the eyes. The sides of the eyes, it goes, the person will not be able to see half the eyes to the back.
Now, what happens with when a person is having a migrainous episode, at that time, there's a vascular phenomenon going on that reduces blood flow. That's why they have that funny, after the flashing lights, they have that sort of, we call it a scotoma, right? Like a dark area. Yes, but that clears up again.
It does clear up, yeah.
It's not the same as glaucoma. With glaucoma, once you have those dark spots, they're not going anywhere. They're there for life. So it's a different thing. So no, there's no, if you search, this is the information age. If you go search about risk factors for glaucoma, migraine isn't listed as one of them. That doesn't mean that a person who has migraine cannot go on to develop glaucoma. He may have a genetic predisposition, or he may have a secondary event that has led to the glaucoma. I don't know if you understand what I mean, but migraine is not a predisposing factor as such for glaucoma.
Thank you very much.
Sister Yetune will take the last question. The last people raising their hand. Go on, Sister Yetune.
Thank you. Thank you very much, Dr. Alimi, for that clarification. And so we have Al-Aji Ushuba. I don't know if it's Al-Aji or Al-Aja, but there's a hand.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum wa barakatuh.
Thank you very much, Doctor, for this awareness. We really enjoyed it. My question is, right in September, I had some pain in my body, and the doctor prescribed a tablet, which is thyroid, I believe, and they, explained some of the side effects, which I read from the prescription as well. But during the course, I'm still on that tablet, but now I used to have a flashing lights sort of. So I complained to doctor, and she told me immediately that I should go for eye tests for investigation, which I did that very day. And everything that necessary to be done was done. And they said, no problem, that's it's nothing to worry about.
Yeah.
But I still have it.
Yeah.
And this tablet is the tablet that I cannot stop. They say that I have to use it for like 18 months or so. They are reducing it bit by bit by bit. They said I can't just stop like that.
Yes.
So sometimes I just feel worried.
Okay. Yeah, so thank you for the question. Now, you recall that someone else talked about floaters, and I said to her, if you have flashing lights, check your eyes. So
Yes.
I'll explain to you what causes the flashing lights. It's not the tablets that cause the flashing lights. I mentioned that when we're young, we all have this compartment called the vitreous at the back of the eye. And it's full of a gel. It's a thick gel. Once the gel, as we get older, at some point in our lives, that gel starts to get liquidy. It starts to liquefy. And that liquefaction starts in the center of the gel. And so when it liquefies in the center, there's now more space created because it used to be a thick thing occupying it. Now it's liquid. So what happens is the outer part of the gel sort of collapses into that center where there's now space. But before it collapsed, that gel was attached to the back of the eye. And so once it forms, it comes into the center, it has to detach from where it was attached to move to that new position. And it's a gradual process that occurs. It's like peeling something off a wall very slowly. As it peels, when you move your eyes, every time you move your eye and that liquid shakes from side to side, it will tug. It will give a tug to that peeling part. And that sensation registers as a flash. So the flash means that the vitreous at the back of the eye is separating from where it is attached to the coats of the eye. That's not a problem at all. In most people, it will happen until it's completely separated and you stop having the flashes.
Thank you.
The reason you need to check is to be sure that you're not having that separation causing any problems. They have checked, like you said, they've done all the tests and
all the tests that are necessary to be done.
Only thing is, if ever the separation peels off an area where it's attached and it tears open a blood vessel, that's not common, but occasionally that can happen. You will know because you have a sudden change. You will know something has changed. You have a sudden shower of black shadows and you might suddenly find the vision is black or very blurry all of a sudden. If that happens, then you quickly get to the clinic so they can rectify what has happened, check and rectify whatever they can do. But in most people, it will happen gradually and stop. Now, there's no time period for when it stops. So you said since September, some people it might stop within 6 months, some people longer, some people shorter. It depends on the person. There's no fixed time. So you're going to have to just ignore, but what you will notice is that it will get less and less over time. And one day you'll just suddenly say to yourself, oh, it's been a month, I haven't seen any flashes.
I haven't seen any.
That's right, process is complete. But if you notice any extra shadows or a sudden darkening in your vision, get to the clinic.
But otherwise, they gave me a pamphlet that if I see so and so, and there'll be shadows, that then I should.
Exactly. So there's certain things that will get you to the clinic. But it's not, don't think it's a tablet. It's not the tablet. This is a process separate from that tablet. Yeah.
Thank you.
Thank you. Thank you very much, Alaja Oshupa, for the question. And thank you more, Dr. Alimi, for the clarification. Rama, please, could you ask one more question from the chat?
Yes. There's a question that asks, does arthritis cause pain in the eye? So can arthritis cause pain in the eye?
Well, in an indirect way, yes. Because some people who have arthritis, if it's of immunological origin, so you might have arthritis because you're getting older and it's a degenerative change. Or you might have arthritis because you have one of those immunological entities, juvenile arthritis, rheumatoid arthritis. And if that's the case, it can be associated with an inflammation in the eye. I talked about inflammation in the eye. So if you have an inflammation in your eye and it's sort of associated with some of those immunological entities, it can give you pain, redness, watering, blurry vision, pain. So yes, which is why I said in an indirect way, not the arthritis in and of itself, but whatever immunological phenomenon is causing it, if that's what it is, can also affect the eye. So in a way, yes. Yeah, so that's the answer to that question.
Thank you so much for answering the question. Sorry, go ahead, Sister Hitton.
Thank you so much. We are rounding up. We're getting close to the end of our presentation. It's been such an amazing time together. Ajay Sulaiman, over to you, please. And before she comes on, I was just sharing on the chat box the fact that you could look up, you will get a copy of this recording on our website. And if you would like to contact us, you can send us an email. I'm going to send that to you. And should you like to join the Salam Sisters Forum as well, there is a link that has been put up on the Telegram page platform that you could sign up on. Thank you very much. Ajay Sulaiman, bismillah.
Right. A very, very big thank you to Dr. Alimi. That was a really, really in-depth lecture series. And I'm sure you have, you're not just a doctor, equally a teacher, because you had to demonstrate with all parts of your body. May Allah continue to increase in knowledge, taqwa, and ikmah. Right. I'm going to be a bit stingy with time here. I'm going to give you 2 minutes because I know you are equally the director for the charity organization for the children eyesight issue. I'll give you 2 minutes to tell us about that organization, what you do, how could people, who do you serve, how could people access the services, if they need to contact the organization, how could they do that? But just 2 minutes if you don't mind. Thank you.
Thank you so much. Jazakallah khairan. I'm happy that you give me an opportunity to talk about something very close to my heart. And so right. So I'm a pediatric ophthalmologist, which means that I specialize in children's eye problems. And pediatric ophthalmology is very challenging because children's eye problems are usually unique, and people don't realize that children can have the same kind of problems, even at a, you know, a higher dimension than adults. Cataracts, squints, glaucoma can all happen in children. And children, most of the children who have these eye problems, we notice in our environment are the poor, the low socioeconomic group. And so what Restore Foundation is doing is having, where it's action and advocacy for improved child eye health. We are all out there for the disadvantaged children. We know that there are children out there who need help with having their eyesight restored and they can't afford it. And so what the foundation is called Restore Foundation for Child Sight. And so what we're doing is trying to optimize the potentials of children by optimizing their eyesight. And so we have a website where we showcase some of the things we've done, children with cataracts, squints who have had surgeries, whom we've helped. We also want to have children who need glasses, get glasses. We need people to sponsor such things. And we also educate because ignorance is a big problem. And so we undertake education activities. We will plan Zoom lectures like this, public lectures where people can tune in to listen to childhood eye problems and their solutions. We also talk to teachers. So we're basically educating everyone, the patients, the parents, the populace, the policymakers. We also advocate with government to make sure that they try to enact a policy that would be, you know, help with child eye health. We train teachers to know how to get an index of suspicion that a child in the class has a problem and refer them appropriately. So we represent the disadvantaged children. They come to us. We make sure they get their needs, you know, looked after. We have a website. If you go to the website, you see all our activities there. I can put it out here in the chat box. I can also put our email address. Yeah. So if you go and look, you'll see what but basically what we're doing is education and training, intervention and advocacy. So that's what Restore Foundation for Child Sight is all about. Just
Thank you very much. I know you fully utilize that 2 minutes, mashallah. So where are you based, or are you all over the country?
We're based in Lagos.
But for the charity organization, the NGO, the Restore Foundation for Child Sight, where is it based, or is it all over the country?
We're all over the country with the possibilities. Let me say we're based in Lagos, but we will attend to any child who needs help. We have other pediatric ophthalmologists in other settings. You know, there were not many, but they're here and there in the country. So if we have a child somewhere, say in Sokoto or in Kanu or in Kwara, who need help financially, and we know there's a pediatric ophthalmologist there to take care of them, they can't do their bills, we will help them with those bills. But if they're Lagos
how do they contact your organization? How do people contact the organization?
Because we get on the airwaves, so people know we're for Child Sight, and they will get in touch with us. Some of times it's practitioners sending them to us because our colleagues know that we're doing things like that. We're still in the process of spreading the gist. That's exactly what I'm doing now. So we get it into the airwaves. We're on social media. We try to spread the gist. We're going to be having public lectures. So gradually, and then every patient we've helped tells another patient, if you go there, they help you. And so that's how we hope to get, our name out there. And we're already getting a lot of feedback. Yeah, so basically that's what it is. I'm just going to put the foundation's email.
If you put the website on the chat box, that will really be helpful.
That's right. You will know how to contact us. True.
Yeah. Thanks very much to Dr. Halima Alimi for the insightful lecture and demonstrations, I would say, and for your time, mashallah. Now, once again, Dr. Alimi is the MD at Nur Eye Center, and she's the Executive Director, Restore Foundation for Child Sight, which is the NGO, or you want to call it charity organization. And that is the website on the chat box, Restore Foundation nd.org. So you can copy that if you have people that you think might benefit from the organization. Okay, right. We are moving on towards the end of the program. And at this point, I would like to share with the people, those that might be joining our program for the first time, so that you know exactly what we do at Salam Sisters. Our technical director, Rhoda, could you put up this slide, please? Now, in the meantime, we also have a website where you could ask questions and access our previous presentations and lectures. And we do have a Telegram page, not WhatsApp group, a Telegram forum. And that is also on the chat box. Now, we've already posted right there now our website. You could contact us, you could access all of our previous lectures, and you could know the faces behind Salam Sisters. Okay, Rhoda, do you have the slide ready there? Okay, right. While she's trying to get that out, just briefly what we do in Salam Sisters, we are a group of sisters, just as the name says, and we do dawah, and this is also part of it. We do Islamic lectures, and we do lectures that we feel are really important to the well-being of people. So we've done lectures in the past about domestic violence. And thank you, Rhoda. Okay, brilliant. Okay, so this is what we do. We have a Quran memorization group. We meet twice a week, Tuesdays and on Sundays. All of our facilitators, the teachers, are volunteers, and the only thing, the minimum thing we require from the students is that they show commitment by turning up on time and obviously following up after the class to memorize any portion they have been assigned. It is open to everybody, but obviously ladies, because ladies are the teachers and you don't really want to listen to the aura of a female reciting Quran to you. So it will be only ladies. You can join through our Telegram. Just indicate you want to join the Quran group. Rhoda, if you could also share the link to the Quran memorization group, that would be fantastic. Then we equally have the tafsir sessions every Sunday at 5 o'clock, and we'll equally be doing other things on that Sundays. Now, we've run programs in the past, Ask the Sheikh series, where we bring in scholars, knowledgeable scholars, to answer questions on issues relating to our religion, our deen. We've had Sheikh Hakim Asimi from Saudi Arabia. We've had Abu Osama on that platform in the past. Then we've also got a critical thought lecture series, which we organize maybe 2-3 times in a year. And for that one, we address, again, issues relating to our well-being in the society. Okay, and that's about what we do at the moment. We're equally planning on introducing health and fitness. What I would like from you, our audience, is those of you especially who have attended our programs in the past, you might want to let us know which of those programs you've particularly found very helpful and beneficial. And if there's anything more you would like to see in Salam Sisters Forum or lectures, please, we are open. You can add your suggestions in the chat box now, or you could send it into our website. And in the past, we had a marriage conference, which we titled Unique September. And I think our last Critical Thought series lecture was about Ramadan, where we had a 4-week-long lectures on Ramadan and questions related to Ramadan. Now, another Ramadan is coming. We pray Allah spare our life to witness it. We equally have exciting programs coming up for the Ramadan. So please do keep checking from our website, and we welcome suggestions from you. And from me, and on behalf of the Amira of Salam Sisters, Kudrat Atoloye, on behalf of the executives of Salam Sisters, I would like to thank you, our guest, for joining us today, and hopefully you've benefited from the lecture. But a very, very big thank you to our guest speaker for her time and for sharing the knowledge with us, and my co-presenters, Sister Yetunde, and my beautiful daughter, Rahma, who I can always rely for backup, even when I call her in the last minute. So thank you, Jazakumullahu khaira, to everyone. Except Amira has any announcements?
Not at all, just like to thank everyone who have taken time to join us for this program today, particularly Dr. Alimi. May Allah reward you all your effort. Thank you for educating us. Amen. And thank you for giving us this, incredible opportunity to learn. May Allah not make us go blind. And I believe that everyone is going to take away one or two, important messages from here. Okay, thank you very much, all the facilitators. I say Jazakumullahu khairan. Assalamu alaikum.
Wa alaikum salam wa barakatuh.